So if my Ida, is my mic open? Can we get going? Okay. All right, mic is open. I think we'll get going. So I am thrilled to introduce Michelle Tew, who is from the Center for Health Policy, Melbourne School of Population and Global Health, who is going to talk to us about a very interesting analysis she did with Ontario data. And sort of I'll briefly introduce the story of Michelle, and then I'll introduce Michelle. So I think this collaboration came about with her supervisor, Kim Dalziel, visiting Toronto in 2017-18 when she was a Harkness Fellow. And she spent a year sort of traveling around, and we got to know her a little bit. Unfortunately, I was away at the time. And that kind of planted the seed, I think, of some Toronto-Melbourne collaboration. And then Michelle approached us, I don't know, about 2 years ago, year and a half, 2 years ago, with the idea of potentially doing an administrative data study with Ontario data. So there was a lot of hoops to be gotten over and challenges, but now Michelle is coming towards the end of her PhD and has done a really interesting and lovely job of studying sepsis in cancer patients. And she's going to tell us about her work and also maybe about what it was like to work with ISIS data from Australia. So Michelle, please take it away.
Thanks, Murray, for the really nice introduction. So hi, everyone. Thank you for joining me today. I know it's late on a Friday and you'll probably be really keen to start your weekend already. So thank you so much for joining me today. And thank you, Murray, for inviting me to present on my work at the THETA Rounds lecture series. I'm really appreciative of the opportunity to do so here. So as Murray said, my name is Michelle and I'm at the tail end of my PhD. I'm really keen to get it submitted. So for this particular presentation, I'll take you through work that forms part of my PhD research. So in this work, I use population-linked administrative health data to quantify the healthcare costs of sepsis in cancer patients. So before I start, I'd like to extend a very special thank you to and gratitude to all my co-investigators and their valuable feedback and support. So that's Kim, Karen, Murray, Lucine, Andrew, Eric, and Philip. So they've all really helped support me through this particular study. I'll also like to acknowledge my funding sources that I've listed here. So sepsis is defined as a life-threatening organ dysfunction due to dysregulated host response to infection. It is considered an important global health problem and a major cause of health loss. So why target sepsis? I put together some key figures here. So a recent study by the Global Burden of Disease Group estimated that around 49 million people worldwide are affected by sepsis. And they've also reported that 1 in 5 deaths globally are sepsis related. So the inpatient hospital mortality for this group of patients remains unacceptably high, ranging from 20 to 50%. And in Canada, sepsis is the 12th leading cause of death, and 1 out of 18 deaths is due to sepsis. The cost of managing sepsis is high. The cost of treating sepsis in Canada was estimated to be about $325 million annually. So as we can see, sepsis imposes a substantial burden on the patients as well as on the healthcare system. So cancer patients are at significant risk of developing sepsis compared to non-cancer patients. There are numerous factors that contribute to this risk, including the underlying malignancy or perhaps the treatments that the patients undergo, for example, chemotherapy. Studies have shown that cancer patients are 10 times more likely to develop sepsis. Cancer patients with sepsis are 4 times more likely to be hospitalized. So these patients are also more likely to have longer and more expensive hospitalizations. So although sepsis incidence and its associated outcomes such as mortality have been pretty well described in the literature, Majority of these studies were focused on severe sepsis and were not specific to cancer. Existing literature on the cause of sepsis is commonly found in the general population and also not specific to the cancer population. And while we know quite a lot about cancer care costs at the various phases of a patient's diagnosis, it is unclear how much of this burden is attributed to infections or sepsis. And there is limited attention on the economic burden of sepsis in this particular high-risk cancer population. So most sepsis studies present outcomes over a short predefined period, and it does not extend beyond the hospitalization period. So typically a period of 30 days to reflect the 30-day mortality, and this neglects the long-term consequences of the condition to adequately inform on the decision-making process. So the incidence of sepsis is known to be underestimated in hospital discharge data and will likely to only capture those that are most severe, like the severe sepsis cases, and potentially miss sepsis burden incurred outside of the hospital. So in the United States, up to 12% of sepsis deaths occur outside of the hospital and are not captured by studies that rely solely on hospital discharge records. So from our previous work in evaluating a sepsis protocol in cancer patients, we found little literature on the burden of sepsis and infections in cancer patients, which made it pretty challenging when populating our economic models. So this lack of data represents an important gap in the literature. This was further confirmed when we conducted a review of published economic evaluations of interventions involving treatment and management of sepsis. And we found that 3/4 of studies do not include healthcare costs extending beyond the index hospitalization. And the most common cited limitations includes the lack of precise or reliable cost estimates and unavailability of cost data beyond the study period. So this shows that in most evaluations of sepsis interventions, they have not considered the broader implication of sepsis, even when they do extrapolate outcomes to a lifetime horizon. The extrapolation of costs don't follow. So global healthcare expenditures have risen really steeply in the last 50 years, as I've shown on this figure here on the left. Canada is represented by the purple line. As we can see, it tracks fairly well compared to all other OECD countries, although still slightly above the OECD average, represented by the red line. Australia is represented by the blue line, and across both countries, Australia and Canada are broadly similar in terms that we both have some form of universal healthcare coverage, and relatively similar in terms of what the country is willing to spend on health and in outcomes such as life expectancy. So in this era of escalating healthcare costs and limited financial resources, we need to make strategic decisions regarding how we allocate our public health dollars. So it is crucial that we're using the limited available resources wisely to maximize population health gains. So allocation of resources for prevention and optimal care and follow-up of patients with sepsis relies on an understanding of the population groups to target, where to target prevention strategies to improve patient outcomes, and to implement strategies that are of good value to ensure sustained improvement in outcomes and health system sustainability. Current evidence has also shown that sepsis, despite it being an acute illness, is associated with excess mortality following the infection. It is likely that this impact on cancer patients is greater and would impose a significant burden on the healthcare system on top of the cancer care. So having a clearer understanding of what the burden is can help guide resource allocation considerations. And this allocation should be informed by robust data. So the research questions that I aim to answer in this particular study is, what is the cost burden of sepsis on top of cancer care costs? And where on the cancer pathway is this burden concentrated on? And does it vary by cancer groups and sex and age? So the aim of this work is to conduct a match case control study to estimate the short and long-term healthcare costs of cancer patients with sepsis and compare them to cancer patients without sepsis. And we use linked administrative data to conduct this work. With such a rich resource, it provides a unique opportunity to study the economic burden of sepsis across the entire health system. And it can be useful in trying to align appropriate resources for health workforce capacity, infrastructure, including sepsis programs, to achieve efficient allocation of public resources across various services, and also maybe to inform on need for future research. So these cost estimates hopefully will also be able to provide reliable cost data for economic evaluations, for example, to inform economic models for infection control or treatment strategies targeting sepsis in cancer patients. I'll move on to the methods. So patients were selected from the Ontario Cancer Registry, and it included, and these patients were included in the study if they were aged 18 and above, whose first diagnosis was a primary cancer occurring between 1st of January 2010 and 31st of December 2017. These patients were then followed up until death or 31st March 2018. Patients were excluded if they were diagnosed with cancer on the date of death, or if there was a previous cancer diagnosis prior to the study period. Cancer patients were classified by tumor site according to the International Classification of Disease Oncology, the ICD-10 codes, corresponding to their primary cancer diagnosis, and were broadly classified into two groups, the hematological group and the solid cancer group. We conducted a population-based retrospective study using patient-level administrative health data to determine healthcare costs associated with sepsis in patients up to 5 years following cancer diagnosis. So cancer cases were defined as cancer patients with sepsis if they had a diagnosis of sepsis, and sepsis were identified using the ICD-10 codes through published explicit and implicit referencing of sepsis, which I will touch on later. And controls were then identified by a one-to-one match on age, plus or minus 2 years, and were hard match on sex, cancer type, year of cancer diagnosis, and geographical location. So patient-level data on all individual healthcare resource use from diagnosis up to study end date were obtained from ICES in Toronto. So these data describe resource utilization for the 14.6 million residents in Ontario, Canada. These data sources capture up to 90% of all healthcare resources provided universally and paid for by the Ontario Ministry of Health and Long-Term Care. And as we can see that the data captures a huge range of different sort of health services that are provided. So this includes inpatient hospitalization, emergency department visits, cancer clinic visits, physician services, diagnostic tests, long-term care, prescription drugs, chemotherapy, and radiotherapy. So this slide shows the list of data sets used for this analysis and how costs were estimated. So depending on the service type, costs were calculated based on the resource intensity weight provided. For example, for the inpatient hospitalization, which is from the Canadian Institute of Health Information, a discharge abstract data set. So that was calculated using the resource intensity weight multiplied by the unit cost per weighted case. And I did the same for the ambulatory care data set as well. In some other data sets like medication and physician services, the actual costs were provided in the data set itself. So just use the cost as it is. Costing of health services, well, to cost out these health services, I followed the guides by Woodchis et al. On patient level costing using administrative data sets in Ontario. And that particular guide, I believe, has been widely used by researchers using ICES data. So all costs were adjusted to 2018 Canadian dollars using the appropriate inflation indexes. So sepsis cases were identified using codes, using the ICD-10 CA codes, and these codes were sourced from the Global Burden of Disease study published in Lancet in January 2020, so earlier this year. So it reflects the most recent definition of sepsis. So cases were classified into two mutually exclusive groups, the explicit and the implicit groups. So the explicit sepsis cases were those with an ICD code explicitly referencing sepsis as listed, that is listed as an admission diagnosis. So these codes include codes that explicitly has sepsis in their list itself, in the names itself. So for example, anthrax sepsis, streptococcal sepsis, salmonella sepsis, and so on. Implicit sepsis cases were those that that have codes that have both an infection code and an organ dysfunction code listed as the admission diagnosis. So for example, you've got any of the infection codes that are as the infection A codes plus an organ dysfunction code. And so a combination of these codes will, if you have a combination of these codes, you'll be classified as an implicit case. So any cases captured through either the explicit or implicit codes were considered to be a sepsis case. And sepsis case was identified within our 5-year study period and 1 month prior to the cancer diagnosis, just to account for any differences of flexibility in dates. So the cost analysis is undertaken from the healthcare system perspective. We estimate the mean incidence cost of our cases and controls from the time of cancer diagnosis up to 5 years. As we have patients that enter our observation window at different times, not all patients will be followed up for the same amount of time. So this does result in right-centered cost data. To adjust for this, we partitioned the entire period into monthly intervals, and costs were adjusted using survival probabilities following a published method by Lint et al. We then calculate the excess cost due to sepsis by taking the cost difference between cases and controls. And because patients with hematological and solid cancers can be impacted by sepsis differently due to the underlying malignancy and perhaps maybe by the interacting factors such as treatment strategies, risk for infections or neutropenia and so on, we analyze both of these groups separately. To get the 95% confidence intervals for all costs, we bootstrap with 1,000 replicates. Also, as part of this work, we conducted a number of additional analyses. So for example, cost attributable to end of life, which is the cost within the last 6 months before death. Because cost of care at the end of life is expected to be high and an important contributor to overall cost. So costs in the last 6 months of life were then segmented into a separate category, which we term terminal care costs to distinguish these. We also conducted a number of subgroup analysis by sex and age groups. We also conducted a number of sensitivity analysis to test the robustness of our results. So this included increasing the number of matching variables to improve the matching between the cases and controls. And we also tested the time frame of sepsis definition when we excluded the 1 month pre-diagnosis period from our sepsis case definition. And because there's a lot of heterogeneity in capturing different ways of capturing sepsis in administrative data sets with different algorithms of codes, which can lead to variations in our understanding and monitoring of sepsis. We also tested using an alternative case definition following a validated set of ICD-10 codes published by Jolly et al. And also we tested the duration attributed to end-of-life costs. So changing the cost attributable to end of life from 12 months, from 6 months to 12 months. So on to the results. So a total of 485,000 cancer patients diagnosed between 2010 and 2017 met the eligibility criteria for this study. And of this, 17%, which is 83,000 patients, experienced at least one episode of sepsis over the study period, which forms our pool of cases. So of these, matches were found for 77,000 patients. And this means that we have a match control found for 93% of cases. On the right, I have some descriptors for patients included in the analysis. So 64% of patients were age 65 and above, 46% of them were females, and 18% of the cohort had hematological malignancies, and the most commonly being leukemia. And majority of the patients are solid tumor patients, and these are most commonly lung, colorectal, breast, and prostate. So among hematology patients, 32% of the eligible patients were identified to be sepsis cases. And of this 32, the 16,000, we had a match control for 83% of them, which is about 13,000 of them. And these are the patients that we included in the analysis. Among solid tumor patients, 16% of the patients were identified to be eligible to identify as sepsis cases. And we had better matches with the solid tumor group of patients. So 96% of them had a match control. So overall, the controls were well matched to cases except on income quintiles. And unmatched individuals were observed to be older. Most of them were slightly older and more likely to be male, and also more likely to have a hematological malignancy such as myeloma. And across the 5-year period, a large proportion of sepsis episodes occurred in the first year of cancer diagnosis. So among hematology patients, this was 68%. And among solid tumor patients, that was 53%. And also in hematology patients, there was a higher proportion of patients who had more than one episode of sepsis compared to solid tumor patients. So this slide basically just gives an idea of the patient characteristics by the two different cancer groups, which are the hematology and solid tumor. And we can see the age distribution here for both groups, that majority of the patients are in between the age 55 to between age 55 and 84. And in the hematology group, there is a slightly bigger group with the under 34s among between the hematology and solid tumor patients. And in terms of sex distribution, we have about 44% of females, and this is very similar distribution for the solid tumor patients as well. This is a distribution of the income quintile distribution across both the hematology and solid tumor patients. So it's pretty similar across all the income quintile groups, in the range between about 17% to about 23%. And in terms of geographical location, large majority of the patients are in the urban setting, which is 89%, and we get a similar distribution for the solid tumor patients as well. Sorry, that should read urban. So in terms of survival probabilities, so this slide shows the Kaplan-Meier survival curves comparing the sepsis cases, which are the solid lines, compared to the no sepsis controls, which are the dotted lines, separately for the hematology and solid tumor patients. So it is clear that there are large differences in all-cause mortality between patients with and without sepsis across both cancer groups. And compared to patients without sepsis, cancer patients with sepsis have a significantly higher rate of mortality, with less than 1/3 of them surviving 5-year post-cancer diagnosis. This slide shows the mean monthly cost of care between patients with sepsis, which are the brown bars, compared to patients without sepsis, which are the blue bars, also separately for hematology and solid tumor patients. So it is clear that patients with sepsis have a higher cost of care compared to those patients without sepsis. And the differences between the two groups, which is the gap between the two bars, each of these bars represents the excess cost related to sepsis. So we find that among hematology patients, the cost of care of sepsis among patients are at least 2 times as high, more than 100% increase in the cost of care compared to no sepsis patients. And this is particularly so in the early periods of the cancer diagnosis. So among solid tumor patients, we also see an increased cost of care, with sepsis contributing to increased cost of care of up to about up to 85%. So this table shows the cumulative cost of care of sepsis and the matched controls over a 5-year period. So the column highlighted in red represents the excess cost of care related to sepsis. And as we can see, by year 5, which is month 60, the cost of this excess cost is substantial, with $75,000 Canadian dollars for the hematology group and $60,000 in the solid tumor group. So this bar graph shows the excess cost associated with sepsis. So this bar graph is slightly different to the previous bar graphs, as in because these graphs show the excess costs, which is the difference between the sepsis cases and the controls. So this bar graph shows the excess costs associated with sepsis, and the black bars shows the contribution of terminal care costs, which are the costs in the last 6 months of life. So across the 5-year period, between 20 to 50%, averaging 39% of the excess cost was attributed to terminal care costs for the solid tumor patients. So that's the graph on the right-hand side. In hematology patients, which is the graph on the left-hand side, the proportion of terminal care costs increased gradually over the 5-year period from about 39% in the first 6 months to above 90% by the tail end of by the last year of our analysis here. So this slide here shows the heterogeneity plots, which shows the variations in excess costs related to sepsis by sex and age groups. So we see that males tend to have slightly more expensive than compared to females. And the dotted line that you see on the graph is basically the results from the main analysis itself. And what we can see here is also that we find higher excess costs among the younger groups of younger age groups, particularly so for the hematology patients. So this slide provides a summary of the results from the sensitivity analysis. So the inclusion of additional matching variables and exclusion of the 1-month pre-diagnosis period from our sepsis case definition did not substantially change our cost estimates. So there are variations between -3% and 8%. And cost estimates were most sensitive to the case definitions used. So using the sepsis 2 definition showed a lower excess cost ranging between 14 to 13% lower cost for the solid tumors and 3 to 13% lower cost for hematology patients. So applying in the alternate sepsis definition resulted in more sepsis cases captured, which produced lower cost estimates. So this might be due to the high negative predictive value of the approach that potentially could lead to an increased number in false positive, which is why we capture a lot more sepsis cases. And unsurprisingly, the proportion of end-of-life costs increased from 55% to 77%, and from 39% to 54% for the solid tumor patients if we change the proportion of end-of-life costs from 12 months to rather than 6 months in our main analysis. So implications. So what do our results indicate? So as we were seeing that the excess cost related to sepsis associated with high sepsis is highest in the first month of cancer diagnosis and remain high in the first year. So this coincides with the initial phase of cancer care, covering the diagnosis and initial chemotherapy periods when patients are at increased risk of sepsis with neutropenic fever and other infection. So this highlights the need for increased attention at this critical stage of the cancer pathway. The results also suggest that there needs to be increased focus on implementation of clinical pathways in hospitals where most sepsis cases are diagnosed, and also to strengthen initiatives for prompt sepsis identification and diagnosis, particularly in the first year of cancer diagnosis. So this does reinforces the need to act early and fast. So there have been numerous initiatives to manage and treat sepsis and to improve patient outcomes. These include integrated protocols or sepsis treatment bundles, such as those developed as part of the Surviving Sepsis campaign. And there has been a lot of effort in developing sepsis management programs, and these clinical pathways for sepsis have demonstrated efficacy in reducing mortality. And many of these pathways have also been demonstrated to be cost-effective strategies. So this includes an evaluation that we have conducted on a whole of hospital sepsis clinical pathway in a cancer hospital here in Australia. On the right, I show the results from this particular evaluation that I conducted early on in my PhD. So basically it shows the results from the evaluation, which shows on the cost effectiveness plane on the top right-hand side that the pathway has an average ICER of $7,500 per QALY, which is deemed to be pretty cost effective by Australian standards, where we usually impose a threshold, an implied threshold of $50,000 per QALY. It also demonstrates that effective implementation of sepsis pathways can have a big impact in driving down costs and improving patient outcomes. So if you're interested in my paper, I've included a QR code here, which you can scan using your phone to get access to the paper. So we can also see that under the $50,000 per QALY, which is this the graph on the lower right-hand side, showing that if we have a willingness to pay of $50,000 per QALY, the probability of the sepsis protocol to the probability of sepsis protocol to be cost effective is deemed pretty high in this case. So the use of population-linked health data sets, which captures nearly all publicly funded healthcare services, there's real power in having this particular type of data sets of capturing a whole of system view of the impact of sepsis. So it does provide a valuable opportunity to gain critical insights on the implications and burden of sepsis across the cancer care continuum, which is not possible without the access of robust linked data sets and systems. So data generated from contact of healthcare system provides important real-world evidence and more accurate reflection on the economic burden across the healthcare system. So they do provide a broader and longer-term view on the impact of sepsis in cancer patients, going beyond the limited hospital estimates that we currently have available. So capturing sepsis cases using the explicit and implicit cases provides also a more realistic capture of sepsis and its associated costs, which can be reflected through sepsis that would be reflected through just using sepsis specific codes only. So undercoding of sepsis can have important implications if used in surveillance of sepsis or planning of resources and allocation of services. So for example, undercoding can result in inaccurate assessments of prevalence, thereby contributing to inadequate allocation of resources for monitoring and appropriate treatment. These cost estimates hopefully will be helpful in informing resource allocations and health policy considerations, and can hopefully be used in cost effectiveness models for decisions on sepsis interventions, and are useful in helping inform development of sepsis protocols of programs and policies across the cancer care continuum, which can include prevention, screening, treatment, and end-of-life care. And hopefully these estimates can be helpful in improving our understanding of the burden of sepsis along the cancer care pathway, which we can then give us an idea of where we can deploy targeted strategies to alleviate this burden. So there are some limitations that should be considered when interpreting these results. So the analysis does suffer from various limitations common to many observational studies. So the cost estimates presented in this study should be interpreted as associations rather than a causal impact of sepsis, but they do offer a measure of economic burden of sepsis care in cancer patients across the 5-year diagnosis period, which has not been previously quantified before. So the presence of sepsis can be confounded by a number of factors, such as cancer stage or grade or at diagnosis and treatment factors, comorbidities, and so on. So although we have attempted to match cancer type, complete information on the potential confounders such as stage and so on were not available for further matching in the analysis. So it is possible that, for example, patients with sepsis that have late stage cancer, patients with sepsis had a late stage cancer at diagnosis and were on more aggressive treatments, which can predispose sepsis cases to incur higher costs. So this can result in an overestimation of the excess cost of sepsis. And also, we know that there are large variations in survival and costs across different cancer types, and further exploration of the burden of sepsis to reflect this heterogeneity will be really important. There are also quite a lot of differences in the codes used to capture sepsis from administrative data sets, which can lead to variations in our understanding and monitoring of sepsis. So this can result in differences in the cost estimates produced, as we have seen in the sensitivity, in our sensitivity analysis. So future work. So with this incredible resource that we've got access to with the ISIS dataset, we do plan to continue our work on this particular project, which is to generate more cost estimates to further improve on our understanding of the burden of sepsis. So we do hope to generate cost estimates across different healthcare services for different cancer types, some of which I've listed in the table here on the screen, and also by across different treatment phases. So the initial phases of the cancer diagnosis, the continuing, and the terminal, which are the common sort of like the phases that have been used in quantifying cost estimates in cancer patients. And also we're wanting to understand some of the predictors for high cost sepsis patients. So what predisposes these patients to be incredibly high costs. So just to conclude this presentation, there is real power in population-linked administrative data sets, and it provides a whole of system view of the impact of sepsis, and it also provides important real-world evidence. It provides a valuable opportunity to gain critical insights on the implications and burden of sepsis across the cancer care continuum and going beyond the hospital estimates that are currently available. So sepsis is a high-cost, high-mortality condition in cancer patients that requires urgent need for interventions and health policies to alleviate this significant burden. And we've seen that cancer can result in a doubling of cancer care costs, particularly so in the hematology patients. There should be more effort that should be focused in the first 12 months of cancer diagnosis, where mortality and costs are highest. And also, as we know, that there is significant heterogeneity in cancer population, and this really needs to be explored further. So thank you, everyone. I'm happy to take, if you have any specific feedback on this work or any questions or comments, I'm happy to take them.
That's really amazing work. I don't know, can you hear me?
Yes, I can hear you.
So I will start off unless somebody else has a question. I don't see any questions in the chat. So I will just maybe start. That was a beautifully presented and very comprehensive analysis. I guess my main concern about this kind of work is that you wonder whether you've been able to match carefully enough the sepsis and non-sepsis patients. I mean, there's such an enormous difference in mortality across these groups. There's like a 30 or 40% difference in cumulative mortality at 5 years, which is an absolutely enormous effect. So, maybe sepsis has that effect. Maybe sepsis, has an attributable mortality of that size, but I think just intuitively, it seems like it's perhaps too large. And I wonder if maybe a more detailed matching procedure might result in an attributable mortality rate that's a little bit smaller.
Thanks, Mary. That's exactly right. I think there is much more that should be done with the matching in terms of trying to match these patients a little bit more closely to try and understand, to get an accurate picture, a better picture of the sepsis. Unfortunately, the number of, although this particular resource that we've got is incredibly rich in data, there are not a lot of information in terms of, there is incomplete information in terms of in terms of the information that we've got with regards to staging or comorbidities or and so on. But I understand that there are, and we've done our best to try and match as closely as possible. And also, I guess the more matching variables that we include in the analysis, it's the less number of controls that we can find for all these matches. So it kind of decreases our pool of cases within it. So that's what we've done with our sensitivity analysis. But I have seen a number of other papers that have tried to match, to try and get a picture of comorbidities of this group of patients using the Johns Hopkins sort of like an index, trying to understand the patient's healthcare resource use to map this into an index that demonstrates some sort of comorbidity to indicate the comorbidity of these patients. So perhaps that's one way that we can improve on it. And also there are other ways of matching too, like propensity score matching, which perhaps will help too. But yeah, so with this particular, yeah.
That's great. So I have another question from Anna Rozepka. She says, great presentation, Michelle. You mentioned that young people show a greater increase in costs due to sepsis. Do you have any ideas on why this may be?
What I found with the analysis that I've done is the younger patients have a greater increase in the cost due to sepsis, the excess cost. And I found that it's the patients in this group of patients, in this age group of patients, the younger patients, that the cost of managing cancer in the controls was much lower than these other groups of patients. And the sepsis costs were much higher. The cost of cases in this group were much higher. So it'd probably be that these patients, when they had sepsis, they probably would have been put on more aggressive treatments because of their age group. I don't know, maybe perhaps the clinicians can tell me. I'm not a clinician per se, but I think that might be the case, that younger patients are typically on more aggressive treatments than older patients, which is why I guess those with sepsis have much, much higher costs, which results in a greater excess cost.
I mean, the inverse of that question is, why did the very elderly have such low costs? I mean, the younger patients had higher costs, but you also showed that as you got into the over 60, over 70 group, their attributable costs just dropped way off.
Yeah. In that case, in this older age groups, I found that the controls themselves have the sepsis cases, the cost of the sepsis cases were much lower, and also the controls themselves have a slightly higher cost too. And I think because of this age group, they are close. They typically have, I guess, more comorbidities, and they're patients of older age groups, which usually predispose them to higher costs anyways. And also they might be closer to death, which might probably have an impact there, where when you're closer to death, your costs tend to be higher than normal.
Here's another question from Geber Medden. He says, nice work and informative presentation. One concern I have is that you didn't do the matching for comorbidities. This is something that you addressed when you were talking about Johns Hopkins. Do you think it would affect your conclusion?
Well, I suppose with this piece of, it might or might not, I'm not 100% certain, but I suppose with this piece is we're just, what we're trying to do is trying to get an overall picture of the burden of sepsis in cancer patients in general. And I take everyone's comments that, perhaps a more careful matching and with comorbidities and so on would give us a little bit of better picture, which I plan to do in the next, in my future work when we sort of like drill down on specific cancers, with specific cancers, and also an understanding of where does sepsis actually incur along the sepsis, along the cancer pathway, as we've seen, maybe a little bit more detailed analysis in that sense. So with this piece of work, it's mostly just to have a broader understanding, a bigger picture, and maybe in that sense, it may or may not have such a huge impact that would change this, that the cost of sepsis is substantial.
Yeah. Well, that's really good. Are there any other questions? I mean, while I'm waiting for other people to formulate their thoughts. So, you did some very nice cost effectiveness analyses, looks like, before you actually started on this empirical work to try to estimate the true cost of sepsis. Can you talk about how the cost that you used in your cost effectiveness analysis before you knew the true cost of sepsis, how that was different from the empirically derived costs that you measured in this study?
Yeah. So yep. So before this, yeah, we actually did a cost effectiveness analysis of the sepsis protocol. Perhaps I can show. So this one here. So I did a cost effectiveness of the sepsis protocol that was implemented in a cancer hospital here in Australia. And because there were not a lot of costs beyond the hospital, and basically we implied the cost using what's available out there, which was some of the hospitalization costs from available studies, and also using coefficient regressions to incorporate costs on cancer patients itself, cost of cancer patients across the lifetime horizon. So in this, it was difficult to try and scour different sort of literature out there to try and incorporate costs. But the good thing about cancer costs, there are many different types of literature that is available out there to try and capture cancer costs. With sepsis costs, we had a little bit more of a challenge. It was easier to incorporate the impact of sepsis or mortality estimates in our model, but with costs, it was difficult. So we had to make some assumptions that this costs were actually built into the cancer cost itself. So beyond the hospital costs, the sepsis, basically the intervention costs only included the sepsis costs within the intervention and not beyond that. So basically just the hospital costs. So we did not, so hopefully with estimates that I've done here, we could perhaps try and plug this into this analysis and see how it differs, changes our analysis really.
Cool. Okay. Any other thoughts or questions? Last chance. Michelle, do you have any questions for the audience?
Well, I guess I'll stop sharing my screen. Perhaps I will maybe, you did touch on this earlier on in the session where you said that it'd be nice if I could share my experience using the ICIS data and why is an Australian researcher using Canadian data sets. So maybe I would share a little bit of my experience that, the Canadian resource with the ICIS, it was challenging trying to get access to the data set, but at the end of the day, we did manage to get access to the data set, and it's an incredible resource that, that it can cover such a huge range of healthcare resources, and the detail of the amount of information that's captured within the data set is incredible. which allows me to answer a lot of different questions and use this for my PhD. And the reason, and it was really a really steep learning curve for me to try and work on this huge data set, because I've never before I've worked on such a large data set. And I suppose getting access to the Canadian data set was actually much easier than getting access to a local data set here, which of the same size and of the same granularity and detail. So I suppose the infrastructure of population-linked data sets there in Canada and the accessibility of data is much better than what we've got here in Australia. And also, I think although it came at a cost, it was much more affordable compared to what it would be here in Australia. So which is why it was a great opportunity for us to tap on such a huge resource. Beyond that, I've had a great time working with Murray and the team and everybody else in Canada, which was really incredible. It was, yeah, I've really learned a lot working on this data set, and I'd like to thank everybody. I'm happy to, hear if you've got any comments or questions or suggestions on how I can improve on this work. And yeah, because moving forward, I'm working on quite a few other analysis. I'm trying to capture the costs, as I've mentioned in my future work, of the cost of sepsis in this group of patients. And I'd be happy to hear any suggestions on how to improve it or improve on my matching or type of analysis and so on, because it is pretty challenging to try and capture longitudinal costs. And on top of that, it's sort of like sepsis is an infection that occurs sporadically within the cancer care continuum of the patient's pathway, really. So I'm happy to hear from anyone, really.
Okay, that's amazing. I think we'll wrap it up. I mean, it's almost 5 o'clock here. It's almost 8 o'clock for Michelle in Australia, and we really appreciate you getting up so early on a Saturday morning to share with us. And thank you for those of you who have had the patience to stick with us till 5 o'clock on a Friday. I think
Murray and Laura has a question, actually.
Oh, a question.
Laura, yeah, she says, thank you so much for sharing, Michelle, your work and perspective. Hope it would be okay to connect with you. Would you mind connecting with people if they're interested, Michelle?
Of course, I'm happy for you to get in touch with me. I put out my contact details previously, so hopefully you've got my email address. If not, you can find me on the University of Melbourne website. And happy for you to get in touch with me. More than happy.
Great. Okay. All right, we'll let you all go. Thanks again. It's just like a great beginning of a research collaboration, hopefully, and lovely to see you, Michelle. And thanks so much for presenting again.
Well, thanks, Murray, and thank you, Ada, for organizing this, and thank you, everybody, for spending your Friday evening listening to me.
Okay. Okay.
Thanks.
Bye all.
All right. Bye.